I apologize. There's a feed interruption, but I'm going to continue from the slide that we stopped on. Thank you all for staying. I really appreciate it. So if a clot forms and does not resolve, it will extend proximally into the popliteal and the femoral veins. 25% of calf DVTs will extend proximally within 7 days, so that is a short period of time. Also, 96% of DVTs arise from the lower extremities, and only 4% arise from the upper extremities, like things like your PICC lines and trauma to the area. So some interesting facts that I found: 90% of PEs arise from DVTs. It's a huge amount of PEs. 50% of symptomatic proximal lower extremity DVTs have asymptomatic PEs, so meaning that the patient isn't aware that they're having a pulmonary embolism until it's too late. 70% of PEs have asymptomatic DVTs, meaning that the thrombus in the deep vein thrombus wasn't caught by either the healthcare professional or the patient. So it then breaks off and goes and forms a pulmonary embolism, which is the life-altering event. So that brings me to signs and symptoms. Pulmonary embolism, signs and symptoms. This is when a clot breaks off and goes into the lungs, obstructing the patient's ability to breathe. So they're going to have sudden onset pleuritic chest pain, very, very painful. They might be clutching their chest, shortness of breath, difficulty breathing. They might have some sort of labored, agonal breathing, and it'll be audible. You'll be able to hear it. Tachypnea and tachycardia, so high heart rate, high respiration rate. Dizziness, fainting, and loss of consciousness. So, this creates an anoxic injury, and the patient can no longer breathe, so they do end up losing consciousness. The first code that I ever experienced as a nurse was a pulmonary embolism patient, and my patient did lose consciousness and was blue within 30 seconds. So, another symptom might be hemoptysis. This is an early sign, bloody cough. And then signs and symptoms of deep venous thrombosis. So this is very, very, very important that we catch as early as possible, if not prevent. It'll be asymmetric swelling. So if it's in the upper extremities or in the lower extremities, you'll walk in to do your head-to-toe assessment, and your patient, their calf will be larger on one side than the other, and it'll be swollen. Pitting edema on the affected side, so you'll be able to actually, press your fingers into the edematous tissue, and it'll create a pit. Pain from the site, the patient may not be able to move it, or may say, hey, my arm hurts, or my leg hurts. And then Homan sign, and also heat from the site. When you feel the swollen affected area, you'll be able to feel it's hot, not cold. Cold would mean we're not getting any perfusion to the area. Hot would mean we have most likely a deep venous thrombosis, so we would need to get a Doppler and ultrasound to detect the clot. So non-pharmacological prevention, one of the things that we really like to stress is our SCDs and our foot pumps, if your hospital uses those. We primarily use SCDs, or sequential compression devices, or intermittent pneumatic devices. They can either be calf high, knee high, or thigh high. And they are hooked up to a machine, and they slowly squeeze the patient's legs and kind of mimic what they would be doing if they were moving or walking around their house. And those are on 24/7. So this is a cool chart that I found that actually tells you what the percentage of the graduated compression, like how it works on the patient's foot and calf. So it starts out at like 100% towards the ankle area and moves up to 50% closer to the knee. So it's actually pushing blood from your most distal extremity back to the vasculature. And then early ambulation, this would involve your physical therapist, your occupational therapist, the nurses, your CNAs. If the patient can get up to a bedside code or bedside commode and go to the bathroom, that is even, if that's as much as they can do, then that's even beneficial. But walking them around the unit and getting them to do things like brush their own teeth, things that would require standing and a little bit of exercise is really, really beneficial. Walking promotes oxygen throughout the body and maintains a normal breathing function, and it strengthens the muscle tone so you won't have that stasis, the venous stasis that we want to avoid. So this is a slide on heparin. We're all familiar with heparin, I'm sure. We give it subcutaneously every 12 or every 8 hours. The advantages are there's no monitoring required, and it's dosed based on weight, and it reduces the platelet activation. And then the unfractionated heparin, limitations of that would be the risk of HIT or the heparin-induced thrombocytopenia. In 5 prospective studies, the rate of VTE in patients in critical care not receiving prophylaxis ranged from 13 to 31%. Because signs and symptoms of VTE are frequently silent and can lead to fatal pulmonary embolism, multiple professional organizations recommend VTE prophylaxis for at-risk patients. So we use that. We take that very, very seriously and try to use that when it's not contraindicated. So our take-home points, on admission, we want to obtain an accurate history and physical on the patient and consider the admission diagnosis as a part of the consideration for VTE prophylaxis. Second they walk in the door, you want to make sure that they're on some sort of thrombus prevention method, whether it be ambulating, SCDs, or heparin, or all 3. Mechanical prophylaxis should be initiated in patients who cannot safely receive pharmacological prophylaxis, like I stated previously. So anytime that you have a patient who has a PICC line or something like that, you're going to want to make sure that you're measuring their arm to make sure that you're not getting a clot formation. And so if it's in the upper extremity, you're going to go to your centimeters, measure from the crease in your elbow up to the top of your shoulder. Whatever that middle number is, you wrap it around and you get your centimeters, and you want to make sure that we're doing that every single shift to make sure that clot formation is not developing in the arm that has the line in it. So does anybody have any questions? I did give all of you a post PowerPoint questionnaire, and so please fill that out. There is a test, and I'll just take those in the next couple of minutes. Again, thank you so much for coming, and my name is Audrey Bautista, and this is my presentation. Thank you.